Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Very good. Thank you, Katie.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and our lone US COVID statistic through today, September 26th. We invite you to submit any questions you have down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with that COVID statistic, average COVID deaths per day in the last reported week were 26. In 2024, we saw 175 COVID deaths per day in the same week. Dr. Murphy, your reactions to those numbers and the current state of COVID in the US?
Yeah, so nothing really much has changed over the last few weeks. These numbers are all the same. So there's still 26 people a day dying of COVID, but that's markedly less than last year, which was less than the year before. So it's kind of winding down. It'll be interesting to see what happens next year, if this will continue, or it just stays at this kind of level. But what is happening now, in terms of the number of cases, of course, we don't really know because it's not a reportable disease any longer. And most people make the diagnosis themselves by just buying a test kit in a pharmacy. But if you look at the wastewater activity, which is a surveillance program that is ongoing, the amount of COVID in wastewater is high. So we had the summer bump, and then it started declining a little bit, and then it's kind of bumped up again, probably because people come back from their summer vacation and gone to school.
Yes, very important to note there, and we will, of course, keep up to date with those numbers. But we do have some new research this week, this time on nirmatrelvir ritonavir, which we talk about as Paxlovid. Can you tell us about this study?
Yeah, this is a study done in Taiwan. Taiwan has a very centralized medical system and records for everybody. They're looking at the drug Paxlovid, which is the combination drug that is most commonly used for people that are not in the hospital to treat. And we've done clinical studies looking at this, but this is a huge population study with 2.3 million people aged 12 and older, whether they got Paxlovid or they didn't get Paxlovid. It's not a randomized study, but it's a population-based study, but it's enormous. And what they found is the Paxlovid treated people did much better. They had significantly less hospitalizations, like 68%. ICU admissions down about 60%. Invasive ventilation, all about the same, including the death rate, which not that many people died, but people still did die. Obviously, they're dying every day of it. The death rate was down by almost 60%. So it basically it works. It hasn't stopped working. So I think it's important to keep up with these studies because very few people I see now are taking treatment. And particularly if you are at all in a risk group, having any underlying disease, or you're 65 or older, or anything is going on with you medically, this is a drug that can help you um, uh, uh, avoid some of these terrible complications.
Mhm. And another group who we don't see from the data that is as risk as severely as the older people are children. Yet there was just a very interesting study looking at long COVID in adolescent and that rate that it occurs. Could you break down the data for us?
Yeah, so this is a study in basically teenagers, 12 to 17 years old. This is in the Journal of Infectious Diseases, which is a very respectable journal. And they looked at 784 adolescents were included in their analysis here. about a third of them tested positive for COVID. And then they followed those kids and saw what happened to them medically. And the COVID kids had uh, much more, many more neurologic symptoms like fatigue, headache, difficulty thinking, just feeling bad. They had sleep problems. The rate of those kind of symptoms was much higher than the kids that did not have COVID. And this went on in many cases for months. So, we don't really have a good definition for what long COVID is. I don't know if I would call this all long COVID, but I think the point is people think, oh, COVID, you just get COVID, you get better, there's no need to worry about it. But in these adolescents, quite a few of them had symptoms for many months. And if people have had their children who got COVID and noticed that, there's some issues with them afterwards, it's from COVID. And it just brings up the whole issue of universal vaccination for COVID. Our recommendations had been basically everybody 6 months of age and older. Same thing what we do for the flu. And if you're getting that many symptoms in a teenage group, who knows what that can lead to. I mean, it certainly can't be good. But anyway, I think the whole idea that COVID is just a minor thing and it just goes away in a couple of days is not true in many people, and including in teenagers.
Absolutely. And it's very important to note that while we have gotten out of the main height of the pandemic, we don't know what the long-term effects of long COVID or just the general illness will be.
Right. We have no idea.
Now, there were several major news stories regarding infectious diseases, vaccines, etc. this week, starting with the president's decision to link autism to Tylenol. Can you break that down for us?
Well, this kind of came out of the blue. First of all, Tylenol is a trade name for a drug. Acetaminophen is the actual real name. And it's very commonly used because, and a lot of people, if they get some minor fevers or aches or pains, they can take aspirin, but aspirin can cause trouble in children and in pregnant women. So, most people, if they have some minor symptoms, they'll take Tylenol. All right. Now, Tylenol by itself is very well tolerated as long as you don't take a whole bottle of it at the same time. So, but anyhow, there have been some claims that it's associated with autism. Well, an association with autism is not meaning it's caused by autism because so many people take acetaminophen. It's now become basically a target, one of the targets of people, looking for causes of autism. And, there were claims made by the president, avoid it, tough it out, don't take it. All of a sudden we've gone from, oh, vaccines cause autism to all of a sudden it's like, no, it's not vaccines, it's Tylenol causes autism. Okay, no experts believe this. Let's start there. It just so happens, because this issue has actually been around for a little while. Last year, there was a study in Sweden, a country of about 10 million people, also very the health records are very essentially managed. 2.5 million children in Sweden were studied looking at their exposure to acetaminophen, Tylenol, their exposure in utero when they're in the mother's womb or as young kids. And in these 2.5 million children, they didn't find any relationship at all with acetaminophen. So that is somewhat reassuring. Earlier studies that had shown a link were not causal. They were associations. And many experts from, very well-known experts around the country say the same thing. that these studies that had shown associations had nothing to do with causing autism. They were just associated. So that, that's where we are with that. There is no proof that acetaminophen causes autism. I mean, if it was that simple, that would be terrific, but it's not that simple. And there's just this rush to find some cause for autism before we really know what causes autism. And we know there's many things that are associated with it, and there's many suspicions that autism has many genetic links and other things. The other thing they came up with is leucovorin, or folinic acid, or folate, which is given to pregnant women to prevent neurologic defects in a subgroup of people that have folate deficiency in their diet for some reason, or they have a medical condition. It's called cerebral folate deficiency, and that is associated with autism. Now, that's a pretty rare condition. No, folinic acid, leucovorin, it's all the same thing here. I mean, you can buy low doses of that. Actually, it's over the counter. The bigger doses are made by a pharmaceutical company, but it's really only for that rare metabolic disorder that people can get it. There have been some case reports saying that folic acid really helped some kids with autism. It does not cure autism, and it's not effective in every person. There's a subsets that may be better. It needs to be studied more. This is great. Of course, we should study it, but that's about where we are with that. It is not a cure for autism. Let's start there, but it may be beneficial in some people, and it remains to be seen who those people are.
Yeah, more studies needed. We'll see if they can get the funding for those. But there was more ACIP, or the Advisory Committee on Immunization Practices, updates after their big meetings last week. Starting with the COVID vaccine, can you tell us their recommendation?
Well, it's this hodgepodge of recommendations that are only going to decrease the vaccine rates for many different diseases. What they're doing is limiting, like for COVID and flu, to talk with your doctor. Fortunately, they're not requiring a prescription. But talk with your provider. Talk with your provider. Okay, you should be talking with your provider. There's nothing wrong with that. But if you want, I mean, all these years you want to take a vaccine, you should be able to take a vaccine. And so they've watered down the recommendations for COVID and flu in particular. The old recommendation had been like everybody 6 months and older should take it if they want it. If you don't want it, you don't have to take it. But now there's all these nuances and stuff. And so states like Illinois has got its own recommendations now. The Western states, Hawaii, Oregon, California, and Hawaii, Washington, Oregon, and California have their own. The East Coast are doing, every state's doing their own thing. And basically they're all saying, don't follow these guidelines because they're confusing, they're unnecessary, and they're just going to limit your access to the vaccines. The other one that they've been messing around with is the MMRV vaccine. So that's the measles, mumps, rubella with the chickenpox vaccine. And so they can come as a 4-pack. Basically, you can get it, all 4 of them together. But in young children, there is an increased incidence of seizures after taking that. Not death or anything, but I mean, you can have a seizure from the vaccine. Kids get a fever and they can have a seizure. I mean, that's not good, but it's pretty rare. And most clinicians want to give that. They make the decision to give that or not to give it. And this doesn't preclude you from taking 2 different shots. You can take the measles, mumps, rubella, and the chickenpox at different times. But that requires another visit to the hospital or to the clinic wherever, or the doctor's office, wherever you're getting the vaccines. So whenever you put another step in like that, you lose some of those people. So from a public health standpoint, you lose a big chunk of people. They don't come for the second shot. They can't take off from work. They can't get it together to come, or they forget, or it just slips their mind. So that's their big thing. After all this anti-vaccine stuff and everything, you have to split it now. You have to make it harder to get. The one thing that's of issue is this whole program, Vaccines for Children, which is a federally funded program that does provide kids with these vaccines. Medicaid, they are keeping the quad vaccine in the program, so that's good. But Medicaid has to follow the CDC recommendations. So then the CDC recommendation says split it, then they can't. Nobody's going to pay for it. So it's just they're just throwing in stumbling blocks to take the vaccines that normally everything was actually working fine. And so now we're going to make it not work fine. So, what we're going to see is a rise in all these diseases in kids. And that's what's going to happen. And that will fuel our measles epidemic even more. So, we have the measles epidemic hasn't gone away. There's 2 new epidemics, little mini epidemics in Utah and Arizona. 27 unvaccinated school-age Utah children, and 42 from Arizona. So all these places where the vaccine rate is dropping down, they're all picking up in this wave of measles epidemic that's going on in the United States now. So there's just going to be more and more of this, and we're going to add more and more diseases to it if we don't, vaccinate enough of these kids.
Absolutely. Like you said, over 1,500 measles cases now in the US during 2025, still the 3 deaths. And with already lower vaccination rates, it's scary to think about what even lower rates could cause.
Yeah, it won't go away. Remember, in the year 2000, we had 0 cases in the United States.
Yeah, declared eliminated in 2000 and now back with a vengeance. But
Yep.
if we look closer at Illinois, we had a historic first powassan case. I hope I'm saying that correctly. Can you tell us what it is and how this patient is doing?
It's a nasty little virus that's spread by a black-legged tick. Illinois had not had a case. So they're more north of here in Wisconsin and Minnesota. And they're tracked by a CDC program called ARBANET, which is still in existence, but is at risk of being defunded. But anyway, this year there have been cases in 9 other states, 33 of them involving neuroinvasive disease, so they get brain problems, and even 1 death was reported from Wisconsin. So it's a rare viral disease that can cause neurologic problems and occasionally death. And we had a case in Illinois.
Something to monitor. And our final story today is something that is becoming less common, a nightmare bacteria that has some level of antibiotic resistance. Can you tell us about the bacteria and why we're concerned about it?
Yeah, so all the antibiotics that we use in hospitals in very severe cases and severe infections and whatever, they're getting more and more resistant to the drugs that we have to treat them. And there are many bacteria that are floating around in hospitals where there's very few drugs that are really available to treat them. And these are very powerful antibiotics that are given intravenously. But what's happening is, in these very difficult, severe infections that only typically respond to these very powerful intravenous drugs, are the number resistant to those drugs is increasing significantly, and as many as much as 400% in certain settings and places. So this is really going to be a problem. This is a problem that will not go away. It's a problem that needs to be nationally addressed. It has to be globally addressed, because these infections, obviously, if you don't have antibiotics to treat it, the people will die from those infections in the hospital. So it will be an increasing cause of hospital-related death, infections that are resistant to every antibiotic. So it's a very serious issue, and it needs to be addressed, and new drugs need to be treated. Developing these drugs is very difficult. And and maybe they only have to be used in a few thousand people per year or whatever. So you have to go through the hundreds of millions or billions of dollars of drug development to get a new super antibiotic made, and then limit its use to only the sickest people. That's not a business plan that actually works. So this is where the public has to come in and support that kind of work, because it doesn't make any financial sense for a pharmaceutical company to do that. So yeah, that's the issue here. We need more of a strong public health approach, and support by everybody, our government, or governments around the world, to address this problem together.
Absolutely. Lots of serious stories today, ones that we will keep up to date on, and reminding you to stay safe and stay healthy. But on that note, I'd like to thank you, Dr. Murphy, for your time and your expertise today. It's much appreciated.
Well, thank you, Katie. Have a great weekend.
Thank you. And thank you all for joining us for this week's episode of Ask Dr. Murphy. As always, any questions or comments, please leave them down below or at any of our social media linked in the description. Have a nice weekend, and we'll see you next week.